Right. All right, everyone. So today I'm going to be talking about occipitocervical trauma. We'll go through some basic anatomy, biomechanics, and then talk about some of the high yield injuries and management of those. So it's definitely important to go over some biomechanics of the occipitocervical junction. It's basically an articulation of the occiput and C2 with C1 as an intermediary. And remember that this junction has some important implications in flexion, extension, and rotation of the head. In fact, 50% of the rotation and 50% of flexion extension comes from this junction. So certainly got to remember this when we're considering fusing to the occiput because it can definitely have a significant impact on our patients. So the cranial cervical junction anatomy is made up of predominantly ligamentous structures in conjunction with the bony structures, but really it's these strong ligaments that are going to confer a lot of the stability here. And the three main ligamentous structures are the apical ligament, the alar ligament, the tectorial membrane, and then of course you have the transverse ligament, which we think about a lot as this is kind of dictates stability of certain fractures. So it's also important to go over some demographics, and you got to know that this injury is bimodal. We can see it in as high as 73% of cervical spine injuries in children, atlanto-occipital dissociation and things like that. And this is due to some anatomic considerations like their head-body ratio. It can also happen in ground level falls in the elderly. So you always want to watch out for head injuries because 50% of these folks can actually have concurrent brain bleeds. So don't want to forget that. And in addition, we always got to go back to the basics and we have to remember the ABCs. The airway is always of critical importance, and these patients are often, high energy mechanisms. Vert injuries, they can occur. Usually they're clinically silent, but there have been times where it can lead to blindness, and at its worst, it can lead to death. So it's always a good idea to have CTAs to assess the integrity of the vertebral artery. So when you're faced with these patients, there can be a multitude of distracting injuries. So you first want to, look at the plain film and assess quickly these important lines: the anterior vertebral line, posterior vertebral line, spinal laminar, and the posterior spinous line. And this can give you a quick assessment of any obvious injury before they're getting any kind of advanced imaging. It's also important to pay attention to the soft tissue shadowing, which can be appreciated. There's some normal values here. Usually you want this to be less than 10 at C1, less than 5 at C3, and less than 20 at C6. Obviously, CT is now kind of essentially a standard, especially in the trauma setting. Most of these guys are getting it right away. So we're able to catch some of these injuries that were historically missed. MRI is, of course, particularly useful when we're assessing any acute disc herniation, hematoma, cord injury, and it can also assess integrity of ligaments, which is especially important for the craniocervical junction. So we'll first start with occipital condyle fractures or injuries, and this usually presents as a spectrum of presentation. It can range from minimal deficit to quadriparesis, and it can definitely present with some unusual symptomology due to the fact that we're in close proximity to the lower cranial nerves as they come out of the jugular foramen and hypoglossal canal. So the occipital condyle fractures, they've been classified into three types. Type 1 is a impaction comminuted type, which is typically stable. Type 2 extends into the basilar skull, which is also stable. And type 3 is usually a little higher energy, and it's an avulsion of the alar ligament. And this in turn prevents apposition of bone and confers some instability. So we may have to treat these patients with either a halo or a fusion. In summary, you can usually treat these type 1s and type 2s non-operatively and get away without any kind of surgery. And then in type 3, you do want to consider occipitocervical fusion should there be any instability. So Atlanto-occipital dissociation, this used to be essentially a death sentence, but we've gotten better at recognizing them and, treating them more appropriately. Children are at higher risk of these injuries, particularly in the high energy mechanism due to as I said previously, their anatomic features. And it's important to note that, again, this used to be a very devastating diagnosis, and it was the cause of death in as high as 35% of traffic fatalities. And one of the issues with this diagnosis was that it was frequently being missed because of all the distracting injuries that the patient may present with. And furthermore, especially before the advent of standard CT protocols, it was being missed radiographically. So definitely have to have a high index of suspicion when and actively seek these injuries out. Just a little backstory. So the first report of Atlanto-occipital dissociation actually came to us from a Navy surgeon, Dr. Blackwood, back in 1908. And back then, the course for this injury was artificial respiration, a supine C3 laminectomy, which you can imagine is quite awkward. And he described it doing it as if he were a fresco painter, and ultimately death. So how far have we come with this? Well, we see some of the first reports of survival back in 1948, with only a few similar experiences throughout the years. However, as the years passed, mortality rates did seem to decrease. There was a recent study in 2021. Young reported a 41.7 mortality rate in their 12 AOD patients. I don't know who that author is on that. He seems like a pretty cool dude. He recently published and demonstrated a similar experience in their single center. Indeed, a significant decrease in the more recent years. So enough of the backstory. When you're evaluating this injury, you want to look at Powers ratio, and this compares the distance between the basion to the posterior arch of the atlas, and the distance between the opistheon and the anterior arch of the atlas. So if you have, sorry, some of this cut off. I don't know if you can see all of it, but if you have a Powers ratio greater than 1, this can suggest an anterior dislocation. If it's less than 0.55, this can suggest a posterior dislocation. You also have the Harris rules of 12. And so you want to look at the basion-dens interval and basion-axis interval. If either of these are greater than 12, you really got to be suspicious for AOD. And then here, when you're quickly looking at the CT scan, you do want to see almost like a golf ball on a tee. You don't want to see too much diastasis or anything like that. This could also be a subtle sign or cue to AOD. You got to be careful when you're first seeing these patients. Traction, if applied early, without appreciating the instability or the injury pattern, can lead to further displacement and neurologic decline. Sometimes instead of putting a C collar and risking moving the spine, you can actually just put sandbags on either side of the neck, and this could is less likely to cause any neurological injury, and you'll have some splinting until you get any further diagnostic information. Once AOD is diagnosed, you want to achieve a safe reduction. Most likely in the OR, you're going to do this, but minimal increments of controlled traction can be used, but definitive fixation is usually achieved with occipitocervical fusion. So going to atlas fractures or C1 fractures, these make up about anywhere from 2 to 13% of all cervical spine fractures. And most commonly, it's due to a fall on the head, an axial load type of injury. And 50% of C1 fractures are associated with other injuries like dens, teardrops, bursts, things like that. And importantly here, neurologic injury is actually uncommon, and that's because when you have a break in the ring, this kind of gives the cord room to swell, edema to come, and it actually decompresses more than causing a compression injury. Stability is dictated by the transverse ligament integrity. You do want to look at the ADI on plain films. You want this to be less than 3 in adults, less than 5 in kids, and if it's greater than that, this could suggest a transverse ligament disruption. You do also want to get open mouth views and be cognizant of some of the lateral mass displacement. CT will best characterize this fracture pattern, and MRI can show the transverse ligament bed. So there is the Landel's classification for these atlas fractures. Type 1 is typically an isolated anterior posterior arch fracture. And this is actually usually a stable injury. Type 2 is the, known Jefferson fracture, which is bilateral anterior and posterior arch fractures. And again, the integrity of the transverse ligament really dictates stability for this fracture type. And sorry, back to this. If they're stable, you can actually put them in a hard collar. And if unstable, you may have to do either a halo or surgery. With type 3, you have a fracture that extends into the lateral mass. And again, you'll want to assess the integrity of the transverse ligament and treat accordingly. So in summary, really, if stable, you can put them in a hard collar. And if unstable in any of these injuries, consider halo or surgical management.
Do you guys see many halos in your residency?
No.
I did 2. Yeah.
Yeah, not a lot.
Pretty uncommon anymore.
When it happened, there was like everyone came in.
Yeah.
I think they're not without complication.
No, we've really gone away. Like I must have put on 100 halos.
Sure.
Well, yeah. I mean, it was like it was all the time.
Right.
Right. And then everyone died, or had horrible complications. So like we've really gone away from it and seeing a lot of these people just in collars. So just yeah.
So atlantoaxial disruptions. This is just, again, as you see a common pattern, it really depends on the transverse ligament. Like anything in orthopedics, mid-substance tears don't heal too well. And so there's very little potential to heal. And so you usually fuse C1 and C2. If it's an avulsion, you can actually immobilize these folks, as there is a 75% healing rate. So DENS, as we'll talk about, there's a lot of controversy, particularly with the type 2 fracture pattern. Very quickly here, type 1 is usually an oblique fracture through the odontoid tip. Type 2 is a fracture through the base. And type 3 is a fracture through the body of C2. And one way to kind of elucidate the difference between a type 2 and type 3 is that the type 3 will typically enter the C1, C2 joint. Understanding the fracture pattern, the patient's age, is kind of important in kind of which direction you're going to go in terms of treating these type 2 fractures. Also, what is the quality of their bone, how much void and cancellous bone. These can all guide you into their healing potential. Type 1, you can almost always treat in a collar. You do want to get some flexion extension films at 3 months. Type 2 odontoid fractures, again, we'll have a little bit more of a discussion, but you actually can treat them with the screw, but there has to be a fracture pattern that's amenable to the trajectory of this screw, because obviously, as you know, you want to be perpendicular to the fracture so you can compress through it. So this isn't always feasible. Also, some body habitus issues. If they have a big barrel chest, you're not going to really be able to get that angle that you need. Type 3, you can put them in a collar, but if there is a fair amount of angulation or displacement, you may want to consider fusing. So again, for type 2 in particular, as I said, this is a controversial topic, and there's been literature all over the place. When we see elderly patients, this injury can be associated with a high incidence of morbidity and mortality. In some ways, it's kind of like the femoral neck of the spine. With type 2 odontoid fractures, there are non-union rates as high as 85%, and this has to do with the watershed area that's there. And some of the risk factors for non-union that are worth knowing are posterior displacement, smoking history, significant angulation, but importantly, there are several reports that show no correlation between non-union and outcomes. So you really need to take into consideration how a patient may tolerate a fibrous non-union, because it's very possible they'd get along just fine and you mitigate significant surgical risk in the frail patient. On the other hand, there are a fair amount of high quality studies suggesting surgical treatment may be better than non-surgical treatment in the short and long-term mortality. So you really just got to weigh the benefit profile, risk benefit profile of the patient and do some shared decision making. And for surgical options, as we spoke about, the odontoid screws is one option, posterior C1, C2, transarticular screws, or occipitocervical fusions. These are all different strategies that can be used. Hangman's fracture. So Hangman's fracture is a traumatic spondylolisthesis of C2, and it has a couple of mechanisms in how they rise. The most common one is probably a hyperextension mechanism associated with an axial load. There can also be some rebound flexion and distraction, which can actually tear the PLL and disc, allowing for subluxation. For these injuries, they're typically in a younger, high-energy trauma setting, and neurologic injury actually is somewhat uncommon. Again, similar to the Alice fracture, where there is some kind of decompression that actually occurs, decompressing the ring, if you will. So type 1 fractures, here we are. Type 1 fractures, these are defined by displacement of less than 3 millimeters with no angulation, and these are usually an oblique pattern. C2, C3 disc is typically intact, and again, alignment is normal. Type 2 fractures, there's a disruption of the PLL and distraction of the 2-3 disc. Type 2A is one that it's actually very important to recognize, as these often have angulation but minimal to no displacement. And here you can have discoligamentous disruption, and you don't want to use traction for these, as you can make it actually significantly worse and see a neurologic decline. Type 3 fractures, these are basically pars fractures with jump facets at 2 or 3. So a little bit more higher mechanism. And with that, here's like an overview in summary of these 3 types. Again, things to note: type 1 is less than 3 millimeters of displacement. You do notice that the C2, C3 disc is intact. It is indeed stable, and so you can put them in a collar for 4 to 6 weeks. Type 3, you do have disruption of the C2-3 disc, and the PLL is disrupted, conferring instability. And so one thing to note is that if there's less than 5 millimeters of displacement, you could potentially reduce with traction and then put them in a halo for 6 to 12 weeks. But as we just talked about, that's not without complications. And if it's greater than 5 millimeters, certainly consider surgery, because I think a prolonged traction or prolonged halo isn't always the best idea for these patients. And then type 2A, remember, avoid traction, as you can worsen their neurological status. And type 3, inevitably, you're going to have to go to surgery to reduce the facet dislocation and stabilize the fracture. So with that, everyone, I just want you to know, if you're feeling sad, remember how C6 is very happy to support you every day. Thank you, guys. Thanks. All right. Found that online. Made my day. Had a run of posterior cervicals recently. So yeah, with Malone and Steven, and that's been good.
Any pearls you've learned from that?
Any pearls I've learned? What's that?
They suck.
They suck. No, I think just being methodical and taking if you hit every step, going through every step in your head, and think nice clean exposure, taking your time with the decompression. Yeah, I think the pearls that I recently learned from a call case is being careful with C2 screws, just really paying attention to the anatomy. And I'm trying to figure out ways to get better at them because, I haven't put a ton in, obviously, but in conjunction with navigation, just still paying attention to traditional landmarks and using both, I think is super important because using one or the other can sometimes maybe get you in some trouble. But for example, C2, maybe putting something there on the medial board of the pedicle can at least give you another, three-dimensional point so that you know where to target your screw. I think that's something I did learn from some stuff. Yeah.
On the occipital cervical, I had my wake up call to that was, I think I was like 1 or 2 years out in practice. Really early on, we were at Sharp Memorial, and I got a call. We had she had like a C6 fracture. It was like a Ditzel, it was like a nothing, and then she was neuro intact, but she was and then because big multi trauma, horrible mechanism, bad car wreck. So she went to sleep and had movement of all four. And they kind of kept her a little sedate, and they woke her up. She was a quad.
Oh, wow.
And they're like, it was the C6 injury. I'm like, no, like, it's not the C6 injury, So we re-imaged her neck, and she had a very clear occipital-cervical dissociation. It was horrible, young girl, like 17, 18, something like that.
Yeah.
So, if you went and looked back at her CT, it was so subtle that it was there,
Right.
And one side was a little bit more distracted than the other, and you could see a little bony fleck, just like you showed. So,
Did you end up taking her anywhere?
oh yeah, she recovered actually.
Oh, wow, that's
Yeah,
amazing.
yeah. But they were log rolling her,
Right.
and when they were log rolling her, her head was just like bobbing all over the place, So,
That's my question. Is
Yeah.
he's like reducing CT where you do like
oh yeah, it looks. I mean, hers. I mean, I wish I remembered her name, but I may have a file on her somewhere. But it was like,
I think I remember that case.
yeah.
I think I remember that.
Yeah, it caused me a lot of stress. So I'm glad you remember it because you were my crutch.
No.
I was like, so like, I guess the point is like, always beware. Like, it's one of those joints that we tend to not look at very much, or you get a call from trauma and they're like, we have a C6 injury, your job is to look at the spine.
Yeah.
Your job is not to be looking at C6, right? And it's very hard to zoom out and be like, hey, my responsibility is to come with a clean slate. Just like every time you go into clinic visits, it's the same thing. Like, you guys may come out and tell me something, but I go in there again with a clean slate. Like, yeah, I have your information, but that's just information, and that's where you'll see oftentimes all of a sudden the patient will say something different. Like, well, they didn't tell me that when I was But that's the whole point. It's like the same with these. Like, yes, the docs may think they figured it out, and then you go in there like, it's actually not what it is.
Right.
So just be.
Any pearls for flipping those folks safely?
Yeah.
In the OR prone.
Just super careful, and I manage the head. Yeah. Yeah. And I mean, you're doing it like you are like doing EMS out in the field. You know what I mean? You're getting that the head super stable.
You put tongs on them still? No weight, or what's your go-to?
For the flip? No,
And even
after
after you flipped them.
depends on the fracture pattern, but in general, those aren't really. You're not really using traction on those. So it's the only time, sometimes I'll build it. Well, that's not true. So I think in general, they're so uncommon, but I imagine I would use a Mayfield because the Mayfield lets you just position the head exactly where you want it, and it locks it there. So I don't love the Mayfield for much anymore. I'm much more of a fan of Gardner Wells, but this is a good place where like you're trying to lock something in sight too in general. So Mayfield's really good for that, where you just position them, get an X-ray, you like where it's at, lock it inside too, But if you have no control of the head, it can be a little bit more difficult. So
Why do you like the Gardner over the Mayfield, you said?
why?
Yeah.
In general, cervical deformity, cervicothoracic stuff, like I want to move the head.
Okay. Yeah.
If you put a Mayfield on, you have a fixed point in space here, and then the rest of their spine is being a fixed point in space. So it's a much more difficult time to surgically manipulate that environment. It's much better to use bivector traction where you can just lift the head up and down or whatever, lift, you know.
Because
In my opinion.
with the Levo thing, you can there has to be Mayfield, right? With that.
Yeah, but you're limited in planes.
Yeah, I see.
So everything's right. Yeah, like I don't want it there. Like it's annoying, you know. Like so, the flop lets you like bend your rod exactly the way you want it, deliver the head to the rod. Like that's
good to know.
That's my
The other unusual or rare traumatic injury is C1, C2, rotary subluxation, which usually is not traumatic, but there is a rare traumatic rotary fixation and subluxation. So you always have to look at that oblique if there's any question that you don't see anything. So we had cases that reported on that.